Hello, everyone, and welcome to the TrialSite News podcast. Farago, I'm Erin, your host, and today we are joined with Dr. Robin Rose, and our focus is going to be on long COVID, which is, of course, a group of symptoms that lingers after someone recovers from an initial COVID infection, and we'll get into that in a little more detail. But Dr. Rose, thank you so much for joining us on TrialSite News.
Thank you, Dr. Stair. I'm so happy to be here with you.
And definitely call me Erin. First and foremost.
Call me Rob.
So do you mind just telling our viewers a little bit about yourself and the work you do?
Sure. So I'm a double board certified internal medicine and gastroenterology. And, I don't know, maybe 10 years ago, I got very interested in understanding root cause analysis and really trying to heal patients, right? Instead of giving a pill for every ill, band-aiding the situation. So I started dabbling in nutritional sciences, that type of medicine, understanding how all these different lifestyle factors, everything from sleep, stress management to movement and nutrition impact health and disease. And then I went back to the Institute of Functional Medicine and I went through all of my certifications and the coursework within a year. They said no one's ever done that. I was up to 2 or 3 in the morning, learning everything I could because I just couldn't believe how we're trained, allopathic physicians are trained in such a way that it's really just an algorithm, algorithmic based medicine. And we just barely even scratch the surface when it comes to biochemistry, pathophysiology, all these different things. So really understanding systems biology from this grand sort of way was amazing to me, and I just couldn't get enough or learn enough. And so I was just so intrigued, and I just wanted to get more and more and more and learn more and more and more. And then once I finished that, then I started going down all the rabbit holes of the gut microbiome and the omics, all the omics of medicine, proteomics, genomics, all the omics. And then I basically, was trying to apply what I learned in my conventional gastroenterology practice, really spending only 15 minutes with a patient. And it was really depressing. And I will back up. The reason why I also delved into integrative functional and trying to understand root cause medicine was because I also had started grappling with my own health issues. And I really just didn't want to take the SSRI of the month anymore. And I wanted to just really be able to heal myself, from the inside out. And so it was really me and also for my family and loved ones to be able to apply this type of medicine to the people I love. So anywho, I basically was miserable practicing the way I was practicing because I really, again, felt while I had an amazing rapport with my patients, I really didn't get to know them at the level I wanted to know them. And I really feel I became a physician to be a healer and really heal people. And I feel by just giving, practicing, multi-pharmacy and just giving a pill for every ill, you weren't really, regressing or reversing disease. And then during the COVID pandemic, I wound up giving notice at my job, and I opened up Terrain Health, which is my, longevity clinic or my functional integrative clinic that we now have here in Fairfield County, Connecticut.
Oh, so you opened that up during COVID?
Yeah,
Wow.
So yes. So I gave my notice at the hospital. I was working for a multi-specialty group, under the umbrella of a hospital system. And I gave my notice in June of 2020, and I opened October 1 of 2020.
Okay. My sister's a practicing physician, so I know all about the frustration with the 15-minute visit and trying to see as many patients.
It's a revolving door.
Yeah.
I took medicine, in and out, 30 patients a day. Plus, I was a gastroenterologist, so the pressure of having to scope and procedures and so on and so forth. And really, that's not what medicine's about, right? Medicine is about really understanding, who your patient is, where they've been, where they are and where they're going with their health in the context of their life, and understanding like everything from the moment they've been in their mom's womb to the present. And we're not able to do that in the conventional space. And we know that the mind, body, and spirit are all like very interconnected and all play a role in how both your emotional and physical health is affected, right? And so we just can't, that's why we suck at chronic, we suck at treating chronic disease, because chronic disease stems from all these different things that we just aren't addressing, right? Like, yeah, awesome if you're in the United States and you have a trauma, like an acute trauma, or you're acutely ill with a horrible infectious, yes, amazing, right? But we failed miserably at addressing the not even epidemic, the pandemic now of chronic disease. So
yes, we are not very good at prevention either. That's for
it's
sure.
all reactive. No, but there's nothing proactive about. It's all sick care, not health care. And, unfortunately, it's only going to get worse and worse, right? And we're just keeping people alive longer, but sicker, not healthier. And there's nothing done to address health span, really.
Health span. Yeah, I always talk about that, health span versus lifespan.
Yeah. I mean, yeah, we talk about longevity. I love the word longevity. Obviously, as far as lifespan, yeah, you could walk outside, God forbid, and get hit by a bus. And but if you improve health span, if you significantly impact health span, you likely will impact longevity if that person is able to live out those years, right? But again, it's about living longer, stronger, healthier, not sicker. And that's what we've done here. And it's,
So you're operating, would you say, outside the scope of conventional medicine?
So, I mean, obviously, a lot of what we do, we still apply conventional modalities and strategies when needed. But yeah, so I always say, Erin, it's really amazing. And this is what I've learned since moving into this space, right? The advanced diagnostic testing, medical device technology, and treatment modalities in this space is evolving at lightning speed. So you have this very small subset of physicians and scientists and whatever keeping up, and then the rest of the conventional world is unfortunately here and has no idea what's happening and how quick and rapidly it's evolving. And it's sad because in order to even keep up with what I'm talking about requires like hours of reading and research, daily, if not weekly, and to be able to apply this type of medicine and these technologies, devices, testing, and all these other things, sorry, patient was leaving, and all these other things to really affect health and prevent disease or regress and reverse disease is unreal. And it's almost like addicting in a way, because you can see how much you can make changes for patients that really partner and lean into this versus like practicing, unfortunately, the conventional way.
Okay. So long COVID, you work with patients who are diagnosed, you diagnose them with long COVID?
Yeah.
Okay.
So I would say starting in the beginning of 2021, I had started really building the practice, and I order, so much blood work. Like I look at all different organ systems. I take a really deep dive because I want to understand how the patient is handling inflammation, detoxifying, how they're handling stress. And so we do, like, when you go to your primary care doctor for a, for your annual physical, like I'm doing like quadruple or even more of that, of what you get done there, right? And I'm really trying to, again, understand, what's happening from a systems biology standpoint. And I started noticing a lot of abnormalities on the blood work, inflammatory biomarkers that I never saw elevated, white counts that were like super, super low, problems with ferritin, TGF beta 1s. I started checking D-dimers that were elevated in everyone, and I just really couldn't believe what was going on. The other thing is I'm a gut microbiome specialist. Like that's really what my niche was when I went into this longevity space. And so I was doing next generation sequencing of the gut microbiome on my patients. And I also noticed that the pattern of their alpha diversity had changed immensely. And so what I had noticed up front was they weren't making their keystone species were trashed. Like nobody was making keystone species anymore. And a few were up to compensate, but the vast majority were really low, particularly the bifidobacteria species. And that was like very alarming to me, knowing that the bifidobacteria are so important in the innate immune response, regardless of like all the other amazing things that they do. But I was very afraid and very worried for what was happening to the epigenetics, right? Like of the epigenetics, not our genetics, it's the epigenetics of like how we express disease and what was going to happen. So I started following this very closely and I got like sucked into it. I just was obsessed with it. I was reading every single article that was coming out like globally. I started getting involved with sort of research consortiums and other colleagues in our country at first and trying to figuring out certain biomarkers that were not abnormal at the rate we were seeing prior to the pandemic. And now we were seeing this and figuring out all these different systems that were being affected and impacted by the virus or the spike protein. And so then that evolved into meeting this one and that one and this one and that one, and then just getting involved with other scientists and researchers abroad in Europe and so on and so forth. And it just like opened up my eyes, and I was lucky enough to be working with these brilliant people all over the world so that I could apply what they were doing from a scientific or even like a bench research, perspective to the clinical side. So I felt like really blessed, and I felt honored that I could help so many people even early on that had long COVID. I mean, we had, 16, 17-year-olds that were wheelchair bound. And I know this is a little bit of a topic, but from the vaccine, we took care of vaccine patients that suffered from the vaccine as well as long COVID. And we were able to get them out of their wheelchairs, and we were able to get them to their high school proms and horseback riding again and doing all these amazing things. And it was just like really being super persistent and, looking at the science that was evolving and coming out and really trying to understand what this disease was doing and how it was behaving, and figuring out and thinking outside the box of what types of treatments you could really apply and give to these patients to really move the needle.
Okay, so the cause of long COVID, you mentioned the spike protein. Is that your top hypothesis? And I'll mention some of the other hypotheses out there, but like, what could you just tell our viewers what causes it?
There's two. It's persistent virus and spike protein. So persistent virus, Carlo Brogna, who I'm lucky enough to work with as well. He's out of Italy. He's published several papers at this point. He actually is the one that discovered, I think he should win a Nobel Prize if you ask me, that SARS-CoV-2 is a phage. It's actually a phage. So it actually invades the bacteria of our gut microbiome. So it's truly an enteric virus. He compares it to the polio virus, actually. And it takes over the bacteria in the gut microbiome, their DNA, and it replicates. And it can persist for years in the gut. And as a result, those bacteria are releasing toxic-like peptides that destroy the gut microbiome, the lining of the gut, cause terrible leaky gut, leaky brain, toxins that then also get across the blood-brain barrier, like conotoxins, LPS, lipopolysaccharide, not those, but I'm just saying in general, the other toxic-like peptides, SPPLA2, all of these different things that are massively affecting the mobilization of neutrophil, all these different things that are massively adding fuel to the fire. So the gut is one of the main what should be one of the main focuses when we're treating and dealing with both acute and long COVID. It's super important that I don't think even 99% of physicians even know or have read these papers. And the spike protein, which if the mRNA is, which doesn't need a cell receptor to get into the cell, gets into the cell, then that cell then can start making spike protein. And if the virus from the wild type virus gets into the cell, which we now know, and then again, everyone's so obsessed with the ACE2 receptor, but we know that there's over 24 different receptors that the virus or the spike protein can bind to get into the cell and take over the cell. And there's so many, and I can start naming them, but I won't. It will be boring. But basically, that's why it impacts so many different systems in our body. And that's why there's so many different symptoms when it comes to long COVID or even acute COVID, because the receptors are so vast and wide and what's being impacted and how the spike protein can gain access to the cell.
Right. And just to reiterate for our viewers, the spike protein is basically what the mRNA vaccines targeted, or they sent our cells a message basically to create the spike protein and then stimulate an immune response. And that's also what
and basically, right, and based on that person's genetics and then epigenetics, right? So when I'm talking about epigenetics, I'm talking about above genetics, right? To explain to everybody. So your genetics, like really, we know now from so much research and science that like really what you express is 15-20% is your genetics, like maybe it at most. But the rest, 80% or more of why you express disease or go on to have disease is because of your epigenetics, how you've lived your life and how you interact and adapt to the environment around you, the toxins that you've been exposed to, like your exposome, how you've handled stress and stress management, how you've slept or don't sleep, how you move, what food you put into your body, all of this stuff impacts your epigenetics, right? And we know that this virus impacts many different epigenetic pathways. And this has been very well researched too. So now our not just our genetics, our epigenetics have now been impacted from this virus, which is a type of a toxin. Like we talk about, we live in a toxic soup as it is, right? And we were never meant, and now we have this other biotoxin that we have to deal with, right? So for many people that were living here, like right below the threshold, right? Or their bucket was just about full, this like tipped them over. This tipped them over. And that's why, oh my God, my light went off. I'm so sorry. Hold on. This tipped them over, and that's why now they're expressing different illnesses, chronic diseases, and it could be any, and when we talk about this, we think it's also impacting everything from the explosion and tsunami of autoimmune disease that we've seen, the explosion of cancers that we've seen, especially in the young adult population, the explosion of cardiovascular events, strokes, clots, pulmonary embolisms, DVTs in young patients, not just old, that we've never seen at the rate we're seeing. So these are things that really need to be talked about, like together in the scientific community. We need to make these observations. We need to come together and like figure out prevention and treatment in such a way that it impacts, health, so that people don't have to go on to have these issues and problems. Because really, at this point, it's tens of millions of people that are suffering from something, right? And then the other thing I always say is, what is someone's long COVID? What is your long COVID, right? Like, is your long COVID because you developed like a really rare autoimmune disease, or because you had a heart attack, like after getting the virus, right? Like in a young person, like things that wouldn't have never maybe happened if you weren't exposed. So that's my whole thing that I've been diving really deeply into, because I just see so much and hear so many stories. And again, I think a lot's missed out there in the world because, and I'm not blaming it on my conventional doctors, colleagues, because I was in that space. But when you only have 15 minutes with a patient, you can't build a timeline. You can't make a temporal relationship when you ask the questions of like when they maybe had COVID or when they had the vaccine, or notice that like when the person maybe had COVID and then they got the vaccine, they got much worse, or vice versa, right? And we didn't have time to study these things either. We didn't have time to see like, okay, people that got COVID, but then took the vaccine, or people that got the vaccine and then got COVID, what would happen to them, right? Or what are we doing, right? So these are all things that like are being brushed under the rug, and we're not talking about it or asking questions or making the observations. And that's why I think a lot of people are so bitter, because everyone knows people that have been infected and all these people know that this happened, but then they're being, it's like everyone's in denial and nobody wants to like, talk about this and address, make it better for a lot of people that are suffering out there.
Yes, I remember I chatted with Dr. Malone about the spike protein, and then really early in the pandemic, and then the interview got taken down from YouTube or got censored. But it's interesting now because I did, obviously there's peer-reviewed journals, published journals now talking about, hey, spike protein is a hypothesis now for long COVID. So it's just my own experience is kind of like, well, now they're at least talking about it and researching it and looking into it. Getting back to how you address long COVID, I noticed on your website, you talk about the long hauler index score. Do you use that?
Yeah, so I did in the beginning. I did when I was working with Dr. Patterson and using a lot of what he was doing. But then I realized that it's not just about the monocytes, from all the research the spike protein, or the virus, it literally gets into every immune cell. Like, and there's a ton of research to support this, like globally. This has been shown over and over again between your T cells, all the PBMCs, they're all infected, and they all take it up. And even the meninges, there's like autopsy reports showing that and it proves that it is the spike protein, that it's like literally embedded in the skull, the skull bone marrow and the meninges and the astrocytes and all the different neuronal stuff. Like it goes everywhere. It impacts everything, right? And so that, to me, just looking at one immune cell, that's not the answer. That's just one pathway or like one aspect of probably over 300 different reasons of why this happens and what impacts person A versus person B.
So do you check, you mentioned the blood tests that you do. Are you looking for specific biomarkers?
Yeah. So we look at a lot of different things. So one of the things we do use as a really good biomarker is I send all of the blood work to Dr. Jordan Vaughn down in Alabama to do the microthrombi testing, because, prior to the pandemic, Racist Pretorius, she's out in South Africa. She's the one that came and trained like 3 of the physicians here in America how to look for the microthrombi testing, but she had protocolized it and showed that in patients with very significant chronic illnesses, they make these microthrombi at like a pathologic level. So like on a scale of like 1 to 4, 3 out of 4, 4 out of 4, that's pathologic. That's not normal. You can have some beta amyloid misfolding and protein misfolding where you have some microclotting in even normal patients, but at that level, it's not normal. So then they were seeing that this was a hallmark sign in many of the long COVID patients, right, that were otherwise healthy and then developed long COVID, right? So we like to use it as a biomarker because we believe that the spike protein, which causes, which embeds itself in the endothelium, causes a low-grade endotheliitis, that then causes platelets to get activated, all these different cytokines to be released, mast cells, so on and so forth, and also activates multiple clotting cascades, which start the process of this microclotting, right? And so we like to take people from the pathologic to the normal range, and then we know at that point that we've gotten to the root cause, hopefully. Again, we need to be able to test this. This would be huge, right? Because we can't actually measure spike protein yet. We measure antibodies and we follow those, especially when people's are like super duper high off the charts and don't have like a positive M protein and say, like it's been like over like a year or two since they've been vaccinated, or it's been like, a year or more since they've had the virus, right? And their N protein's negative, but their spike is very, very high. We like to measure that, follow the regression of the antibody level and then the regression of the microclotting as well. And we use that as biomarkers. And then there's a lot of other markers. We look at like, I would say 70% of our patients, even patients coming in for longevity, their D dimers are elevated. I mean, prior to the pandemic, like when would you see people's D dimers elevated unless they were having like a PE or a DVT, right? That's measuring fibrin split products. Like we shouldn't see that, right? So the fact that so many people have been exposed multiple times, both to the vaccine and or the virus, right? There's probably this low grade, endotheliitis occurring in most of the population. And that's why we're seeing these abnormal biomarkers, the D dimer elevated. We see, lymphocytes, neutrophils super low. We see white counts that are really, really low in a vast majority of people. The human transforming growth factor beta 1, which is something we would measure maybe prior to the pandemic for like mold toxicity or mycotoxicity, that we know basically can, not only cause neuroinflammation, inflammation in different organs in the body, and then lead to scarring. And that TGF beta 1 is significantly activated post-infection or post-vaccine. We've documented this and we've followed it. And then as we treat patients, we like to see that number also regress too. That makes us feel like a lot better as well. And then we look at like reactivated, we look at a bunch of the latent viruses that have been reactivated, like over 2/3 or more of our patients have reactivated, true reactivation of the Epstein-Barr virus. Again, it's all about restoring health and balance to the immune system. The immune system is completely dysregulated along with a bunch of other pathways, but that's what you need to do. And when you do that, a lot of these things then, the latent viruses that woke up, they go back to where they were, those numbers trend down. And again, it's not about targeted drug therapy. It's all about working on a multitude of different pathways synergistically at the same time, because you have to calm all of these things down and they're all impacting each other and causing a vicious cycle.
Right. And what you're doing, I mean, and just for our viewer, there's not a validated test for long COVID. And if you go to the recovercovid.org, the NIH's site, like they're still really at the beginning of this research.
Right.
I just saw they just posted, I think, in the beginning of July, like they proposed a working definition, right, as a consensus, like, hey, everyone, this is what we're going to call long COVID, to try to get a consensus around the diagnosis. So they're really still, right, very at sort of the beginning of this research. And it's, oh, no worries.
My light has like a sensor on it. I don't know why. It's awful.
Which is not a critique or anything at all. I'm just, because it seems like most people, when they go to their doctors, there's a lot of people suffering. Doctors are sort of treating symptoms and kind of like, well, maybe try this, trial and error. That's kind of the stage that we're at now, right? Yeah. The clinical approach. There's no guidelines. There's no consensus. There's no validated test. So that's kind of the Wild West, just to kind of.
Yeah, no, diagnostic, and I can't really reveal what I'm doing right now, but we are working on we're about to engage in a huge research project, which will be able to identify some of the things that I'm talking about that are super key and crucial to like understanding, pathogenesis, what really might, getting a much better look at the patient, right?
Yeah.
And especially also addressing it from the phage standpoint, like I was explaining, and like really understanding what's going on with the persistent virus in the gut and things like that. And so not only do I work on, after like I've cleaned them up and they're so much better, my patients, then we're talking about really prevention and inducing immune, really helping with immune resilience, building immune resilience, and then also doing things, manipulating the immune system in such a way that you can, hopefully lower, not get as, if you get infected, the viral load won't be as high because you're taking certain things, and or you treat right away. You have to treat right away. And treating right away will also hopefully eliminate, especially Carlo Brogna's work showed this, like when you give the antibiotic therapy, whether it's Augmentin or amoxicillin Xifaxan combination, Zithromax Xifaxan if you have a penicillin allergy, that actually the vast majority of those patients did not go on to get long COVID. And that was even in the unvaccinated population. The unvaccinated versus vaccinated did just as well. And so it's addressing, again, going to the root cause and what's happening, right? And so having a better understanding of how the virus behaves, what it's doing from a pathophysiological standpoint, you can treat better. The other thing I'll say too is we address the mitochondria. We use other types of advanced treatments to induce mitochondrial biogenesis, improve mitochondrial reserve and functioning, because any chronic disease we know is a mitochondrial disease. And we know that this really, from doing that to using compounds that stabilize the cell membrane and then harnessing natural compounds that can synergistically work together on a multitude of different pathways, right? Targeted drug therapy, unfortunately, is targeted drug therapy. It's one pathway at a time. We know that there's probably over 300 different pathways that are affected, 79 oncogenic pathways. My group has, discovered that the spike protein or the virus impacts.
And so that means causes cancer for our viewers. Yeah. Okay.
Correct.
So
yeah.
Getting so no, let's you're excited about this. Getting to the natural products is, so I went to your website where you have the protocols, the MediCore.
MediCore, yes, that's with my group in Europe. They patented and developed Medicinal 9 during the pandemic, right at the beginning, actually in January of 2020, to help, intervene, you can't, whatever, I'm not going to call it treatment.
Wait, is this the Spike Detox bundle?
I'm talking about the Medicinals 9 is the backbone product, is the foundational.
Okay.
And that was originally developed during the early stages of the pandemic. And then they saw it was very helpful in patients symptomatically that had long COVID as well. And it's basically 9 polyphenolic compounds. They have both in vitro and in vivo trials, animal studies and human studies showing that what it does, and it actually lowers lots of different inflammatory biomarkers, IL-6, CRP. When they injected mice with the Medicinals 9, and when they induced a heart attack in mice, that and they had a control group, and they gave the other mice Medicinals 9, they literally arrested or prevented the damage to the myocardium. So it's a very powerful product. It's actually, there's also a study that was published out of University of Australia in Sydney, showing that basically it also upregulates P53, which is your tumor suppressor gene, and it showed in vitro that it decreased aggressive lung cancer cells by 50%. So these 9 very potent polyphenolic compounds that were put together purposefully, because backing into all of the different pathways that we knew were being affected by the virus, right? These were purposely chosen because more than one, if not many of them, impact all these different pathways simultaneously and synergistically. And then the way they developed the product was around improving bioavailability. So, meaning it's more potent than many of the other polyphenol compounds because of how it's made and how it's absorbed from the gut and the combination of the different.
So has it been tested in a trial, a randomized controlled trial against a placebo?
They've never done an RCT. No, they have studies though that show that it does these things, right?
Gotcha.
And then they did look at, they did have a few in India. They did have a trial where they had controls, a control group that was receiving, and I can share this information with you and show you,
yeah. Because I could share those.
Yeah, basically in acute COVID, it showed that when you had patients that were already on, because in India, they were using standard protocols, right? They had their own protocols they were giving to patients with COVID. So then that was the control group. And then they added Medicinals 9 to that standard protocol. And the patients, from everything from their chest x-ray findings, right, to these inflammatory biomarkers I was talking about, troponin, were significantly lowered and lowered much quickly than the control group was. And we have that data and those trials to show.
Do you all plan to test it in long COVID patients against
Yeah, that's.
I know it takes funding and all that, but I'm just curious.
I think it's all privately funded because they're so passionate about what they're doing and trying to help the world get better. It's something that's on, it's something that's on the radar, but they haven't gotten there yet.
Yeah, trials are expensive.
Yeah, trials are expensive. And, unfortunately, I understand like everything's about a double blind placebo controlled trial, but also you need to doctor. Like we stopped doctoring, like it's okay to make observations and write a case series and show that patients have done really amazing and well. And,
I agree with you. I just think as long as everybody's honest about the level of evidence, and then people can make their own decision with their doctor. I think
it should be a decision with their doc, right? And if these are safe compounds that our body has evolved with, right, since the beginning of, like, literally, we've evolved with these.
So are these the natural products that you spoke about before?
Those are more than that. Yes.
So this is what you're using on your patients.
Yeah.
And so
that in the beginning, up front.
In the beginning, and you mentioned polyphenols. Is that
right? There's 9 polyphenolic compounds.
So those are because everyone wants to know what's in it.
Yeah. So it's, EGCG, rutin, quercetin, bacalin, glycerin, a very low dose of the licorice, though, lower dose.
Licorice. Okay.
Yeah, but glycyrrhizin, which is people get nervous because it can elevate blood pressure, but it was reformulated so that it's at the dose where it can't do that, right? Like,
okay.
And just like, so again, that's the problem too in the medical space. The vast majority of us are not educated in nutritional science and don't know how to utilize these compounds. So what happens is it's that saying, like, you don't know what you don't know. And so then that gets poo-pooed and not used. And that's unfair, right? Because the doctors that do have a vast knowledge and understanding, and by the way, these compounds have more studies behind them than any pharmaceutical we have, like from everything from how they work biochemically in the body, how they're utilized by cells, what they do, how they impact pathophysiology, like it's unreal, right? Like we have so many studies that back all of these molecules that we're talking about and using. It's just that there's not a double bond.
I agree with you, but I guess it gives it a little bit more confidence, right? If you test it against a placebo, if you have 1,000%. If you can do it, right, then people could say, oh, it actually works.
I don't disagree with you.
Right. 100%. Yeah.
100%. Well, the research that I'm about to embark on now is going to be a placebo, like we'll have a placebo group. This is the other with more of the diagnostic part, but yeah, it will be super exciting.
Okay, so right now this is sort of
I was talking about earlier, not the treatment
that you can't talk about. I got you. Okay.
Come back. You'll come back to me
when you can talk about it. Yeah, this is all interesting stuff.
But then, yeah, go ahead. I'm sorry. Yeah.
No, that's okay. So this is for folks to access this. They know now what's behind it. I think you did a great job explaining it, and it's offered, I suppose, as a supplement. Is that how it's
offered as a supplement for people? But obviously they need to talk to their physician. Like if they're on other medication, they have to have the blessing of their doctors to be able to use it. But it's used in combinations though with it's flanked by other compounds that we know can impact what's going on in long COVID. So we use melatonin. We know that melatonin, and then we have a bunch of studies to support this too, helps restore the blood-brain barrier that has been destroyed too, that we know is a major problem with long COVID, and the infiltration of the astrocytes by the spike protein. We have a ton of studies that support this, and we know that melatonin can impact the restoration of the blood-brain barrier as well as the glymphatic system. So the glymphatic system is what drains the brain of all the toxins and all the garbage when you're in deep sleep at night, right? And so major problem why so many patients have these neuro-COVID symptoms is like your brain's like a pressure cooker. because all this stuff is flying across the blood-brain barrier that shouldn't, right? And then on the other side, your astrocytes are injured because that's a major part of what helps like move things out of the lymphatic system. So it's like you have all this stuff flying across and nothing draining and coming out. So your head, that's why everyone, if you ever talk to a lot of long COVID patients, they're like, I feel like my head's going to explode. I feel like I'm underwater. I have so much head pressure, chronic headaches, the brain fog, the chronic fatigue, like that, all of that's stemming from that, from the pathogenesis of that. So when you treat that and you address that with compounds like melatonin, EGCG, resveratrol, that we know can affect, these different things I'm talking about, it's very helpful for the patients, and so that was something we were doing. And the other thing we were trying to do was, if in fact the hypothesis is correct that there is spike protein, and I don't think it's a hypothesis, because again, there's a ton of studies that show that it induces senescence. It induces senescence, okay? The spike protein. We know when the spike protein gets inside the cell, then that cell, it overrides autophagy, it can't clean itself up, and it moves into a senescent state, okay? When that is in a senescent state, that cell's now a zombie cell, right? And it's like just throwing up all of these inflammatory cytokines, all this stuff that's creating this vicious cycle of inflammation. And then also they start to lose their cell membrane potential, and then they conglomerate into syncytium. The syncytium are a conglomerate of all the senescent cells that harbor all of this garbage inside of it, like all of these, inflammatory immune biomarkers and cytokines and spike protein or virus, whatever's in there, okay? And there's studies that show this. We can show all this, and like this has all been studied around the world. And you can see as soon as, like, literally the syncytium can form within minutes after being exposed to COVID, within minutes. And so this is something that needs to be addressed. So we tried as a group to figure out, okay, how do we break up, if the spike is mostly inside these cells, which we know the spike wants to be inside the cell. It doesn't want to be circulating inside your body. It adheres. It's like a magnet for any cell that it comes into contact with. So then once it's inside the cell, right, how do we break up that cell, mobilize it safely, so that then if you're mobilizing a lot of the spike, that it's not then infecting other healthy cells, right? Bind it and move it out, right? Because if that's the root cause, or if that's what's perpetuating a lot of the patient's, symptoms and problems, then ideally the patient should start to feel better once you mobilize it and move it out of your body, right?
Now, is that in your...
That's part of the protocols that were like developed to help with that.
Okay. So using your protocol, I guess it's considered unconventional at this point. Have you... Yeah. You're like, oh, totally? Okay. Now, have you had luck? Have you seen people recover in your clinical practice?
So we have an 80% or more recovery rate. Now, do some people, so here's what I'm going to say. At this point, too, many people have been sick for 3 or 4 years that we get here, okay? So now it's like, okay, yeah, could that be the problem? Plus, again, they've been infected again, they did whatever, okay? So is that a driver? Of course. But now you have to deal with all of the downstream inflammatory impact and all the downstream issues that have happened that this person's been dealing with for all these years, right? That's so yeah. So of course, giving this to them, do some people say, I didn't feel anything? I have a lot of people say, I'm already starting to feel better. Oh my God, I feel 50% better. I feel 70% better. Yeah. The goal is to get our patients to feel like 80% or more better. That is our goal in the clinic. So once we've introduced these more natural interventions to help, with the patient, then we leverage more, other treatments, and we use a ton of things. We use repurposed drugs that have pleiotropic effects and can impact multiple pathways that are impacted in COVID. We leverage peptides, peptide therapy, again, addressing like mitochondrial health, gut health, all these things that are really, really important. And I feel blessed because we are able to really help our patients. Like we really do, we help them. And that's the biggest gift to me. Like every time I have a patient when they return to follow up and we not only obviously do we take a good history every time they come back, and then we recheck labs and stuff, periodically, but I have my patients fill out what's called a medical symptom questionnaire score. It's put out by the Institute of Functional Medicine. And many of my long COVID patients are well over, 60, in the hundreds, high hundreds. I've had people in the 200s. I mean, that's insane. I mean, from a health optimization standpoint, I want all my patients under 10. If they're under 20, that's considered pretty healthy, right? So this is like, think about how you have to move that needle. But every time they're coming back and that MSQ is going down, 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 and then we just pivot. And that's the thing about long COVID and chronic disease that unfortunately is so missed. Like, it's so personalized, right? It really is personalized, individualized medicine. And you have to be able to pivot with that patient. And all these patients present because of all the different organ systems that are involved. They can really all present that, yes, do they overlap? Yeah, but everyone's unique.
Everyone's a little different. Yeah, I can totally relate to that.
You have to be able to treat them based on that. And again, when I can spend an hour with my patients, and in the conventional state, you can only spend,
which is a luxury if
you're not going to
can't do it. Yeah, you can't do convention.
Right. And what's unfortunate is that this should be free, and this should be available to everybody, and it's not. And
which is actually why a lot of people do go outside of convention. Sometimes they'll be like, oh, you're a quack. I'm like, no, but if you look at they actually started in the conventional system.
We have our results are fantastic,
But they weren't satisfied by that 15 minutes. And then
that's why I left. I was depressed. I was literally depressed. I was depressed. I was upset. I was burnt.
Yeah.
I was like, this sucks. I'm not healing anything. No, seriously, I'm being real. I was like, this is not rewarding for me. Yeah. I'm not connected to my patients. I'm burnt out. Like the pressure of seeing 30 patients a day, like that just sucks. You know? And how are you supposed to even really take care of a patient when you know nothing about them?
And if you don't get your bonuses. Yeah, I've heard all about that.
But think about it, the things I know about my patients, like the things I literally know, like when they fill out my 18-page form and they're telling me their whole life story, which is, by the way, very therapeutic for the patient in a lot of ways too. But like, for me to understand and know them at that level, think about how much better I can take care of them.
Mm-hmm. It makes sense. But you're outside of health insurance.
That's what's that. Yeah.
So okay.
So I work. So one of my passion projects, and what makes me so sad that I can't give this to everybody, right, is I want to be able to. So I work with Chris Cuomo, and we do a Substack together, and we've created a long COVID community. And one of the things that I'm praying, and I hope in the next year or whatever, we're building a fund so that the Substack, whatever Substack you're on, you have to, you have to join. There's a minimal, fee, whatever. So he charges the minimal, which is $5, right? But for everyone that joins, a pretty decent percentage goes to this fund, this long COVID care fund that we want to be able to give treatment to people that are struggling financially, lost their jobs, can't afford, X, Y, and Z, because it's not fair, because everyone should be able to deserve and get this treatment. They should, and they're not getting it. And that's what keeps me up at night. That's what upsets me. So being able to do this is I'm driven to do this, right? Because if we can give this, to however many people the fund can provide for once it really gets up and going, and we can get more critical mass on the Substack, that's what I want to do.
That's great. I mean, that's great. And folks can have a choice then, because right now they really don't, a lot of people can't afford you. They can't afford these treatments. So that's just reality. Yeah.
No, they can't. They can't. And just so you know, to run a clinic we're running.
Oh, I know. Yeah.
It doesn't,
I know.
Even because people are oh my God, I'm like, no. This is
I got it.
I'm working 24/7. I'm working all weekend. My partner and I are up to 11, 12 o'clock.
No, I get it.
On the charts and plans and whatever. This is survival mode for all of us, right?
Yeah.
You're really passionate about something and you really want to help people, that's what you do.
Okay, so the long COVID fund. So I'll make sure to include that link if our
that's for
listeners.
the Substack. Oh, I'll
That's for
give
the
it.
stuff. Yeah, give me all the links.
And what's really cool about the Substack is it's funny. Everyone's like, I can't believe you give away so much free information. Like I literally dive deep into like all of these different
good
things regarding health and longevity. And
okay.
even though we're creating this long COVID community, it's really a longevity community because we're basically using a lot of the things that we harness in the longevity space to the long COVID patients, right? And then once my long COVID patients are better, they become my longevity patient, right? Because now they want to live longer, healthier, right? Or live the years that they're going to live so much healthier, right? And having this disease like really woke them up to being like, wow, I'm going to live like a healthier, better life, right? And I'm going to address these things and work closely in a partnership with my physician to really have like amazing quality of life, right? So that's what's really cool too. Like once we get these patients better, we get to really watch them like still continue to grow as a person and a patient and, avert the crisis. Like I said, avert the crisis. So.
All right. And I'll get those links from you and make sure that our viewers has your Substack, which includes the links to some of the studies I'm sure that you mentioned during the podcast. And
yeah, I can try to get you a bunch of those links to links to a lot of those studies.
Yeah, absolutely. And we'll share them all so folks have them. But this was really interesting. And thanks so much for your time.
Welcome.
Yeah.
It's really exciting work and
yeah,
we're very passionate about it. And, so many people have been suffering for so long. And again,
well, that's what I wanted to emphasize that people are suffering and the research, which drives evidence-based Western medicine, right? Those placebo-controlled trials, they're way behind, but people need help now. So it's a bit like when I talk to different doctors who are treating long COVID, it's a bit like the Wild West. They're like, well, I'm treating this symptom, and people are just kind of like, well, so the kitchen sink right now is kind of, so there's more people who are more like you in terms of like, oh, I think this is the protocol that will work and yada, yada. But
but you do, like we said, you have to pivot and individualize things, like obviously there's certain things that you can give to most patients in the beginning to just like start moving the needle based on what we understand, what of our understanding of what's going on, right? What the pathophysiological drivers are. But again, it really is individualized. And, like you said, it takes a long time to catch up. And God, the virus is going nowhere. And I have patients being infected, not my long COVID patients, even like 2 or 3 times a year, right? And I'll end it with this. I just did a little post about this, but I mean, there's already been 2 or 3 papers in the last 6 months to a year, even one recently a few months ago, showing that even a young person from one exposure to COVID has neurovascular damage, that was it was public. I'll share that paper with you too. I mean, they have gray matter changes to their brain, and they don't even know it. Like we don't even know what's happening to us, right? So if that's happening, can you imagine from multiple exposures to the virus, the spike protein, what is happening, right, at a biochemical, at a cellular level, right? So this is something we have to really take seriously and work together. And I think I'm a huge prevention for me. That's one of the biggest things that I'm really honing in on and trying to work on, because that's the only way.
Because we're not good at prevention.
No,
we have a horrible track record of prevention.
No, and for this disease, it's transmissible no matter what. And the newer variants are just even more transmissible. They just are,
Right.
Are.
Right.
And so we have to take this seriously. We really have to take it seriously.
Right. And I think COVID has
and everyone's sick of it. Nobody wants to talk about it.
Well, right. That's people, it's sort of fallen off the radar. Yeah.
This sucks. I don't care, whatever. But then they show up 6 months later, a year, and this is wrong with them. That's wrong with them. They feel awful. They have this new disease or this new problem. A lot of this is connected. It's all connected. It's not just.
All right. All right. So folks, keep COVID on your radar. Dr. Rose, thank you so much. Appreciate you joining in for the podcast. And for our viewers, make sure you go to TrialSite.com and check out some of the articles there. There's journalistic articles, there's opinion articles. They're labeled as such. And I will definitely include the links to Dr. Rose's site so you can check those out as well.